All right. We are going to settle down, and we have our guest lecturer, Tommy Schafer, here. I'm just going to give a brief introduction, and then they will get started. So Tommy Schafer is the manager of data and evaluation at the Midwest's largest LGBTQ-focused federally qualified health center, or FQHC. They earned their BA in biology from Case Western Reserve University in 2014 and their MPH in Epi from UIC in 2016. Beginning as an intern for their UIC practicum, which is now called the APE, or Applied Practice Experience, which you will all learn about soon. Tommy developed a patient satisfaction survey for the HIV/STI walk-in clinic at Howard Brown Health. Tommy worked in the HIV/STI walk-in clinic as a disease intervention specialist for HIV and syphilis, interviewing and creating case reports for city, state, and federal surveillance systems. And then following that, they were hired in 2017 to coordinate the FOCUS project, a Gilead Pharmaceuticals public health ARM-funded program implementing opt-out HIV screening across the nation. Tommy presented the implementation and evaluation of this program at over a dozen conferences between 2017 and 2019. Amazing. Since 2020, Tommy has managed the data and evaluation team at Howard Brown Health and been involved in numerous internal and grant-funded evaluation projects. They now focus on constructing the yearly Unified Data System report, surveillance of Howard Brown Health's hepatitis cases, internal evaluation projects, and is currently working on 3 research articles regarding transgender men and pre-exposure prophylaxis for HIV, equity of primary care receipt among transgender patients of Howard Brown, and spatial analysis of the availability of LGBTQ affirming mental and psychiatric health services in Chicago. In their non-work life, Tommy is an experienced fiber artist, cook, and quilter. Anyways, love this bio. Thank you so much for being here, Tommy.
Thanks for having me.
Yes, so cool to have people working in the field, and on top of that, an alum of our program. So I will sit down and hand it over. Thank you.
Cool if my mask comes off up here, right?
Yes. Yeah.
Okay. Thank you, everybody. Nice to meet you all. Thanks for being here on this cold Monday. I nearly didn't make the bus. So, my name's Tommy. I'm here to give a talk about the health inequalities in sexual and gender minority communities. There we go. Okay. So learning objectives for today, we're going to understand the language and terms associated with sexual orientation and gender identity. We're going to describe the health inequities that LGBTQIA communities experience at both community and individual levels. We're going to discuss how, where I work, Howard Brown Health, and organizations like it seek to eliminate these disparities, resulting in better overall health for the communities that we serve, which is not just the LGBTQ community. And then I'm going to talk a little bit about my own public health journey. So thanks for being here again. That's right. So quick on me. My context is that I'm a white, queer, non-binary person. I came out in 2011. I hold a master's in public health in epidemiology from UIC. And a BA in biology from Case Western. I've also lived with type 1 diabetes and other chronic health issues since 2005 for 17 years. I grew up in a small, mostly conservative town in downstate Illinois, my 217 area code, and I've lived in Chicago for the past 8 years. I've also worked at Howard Brown for the last 7 years. And I just wanted to preface this with, like, I don't consider myself an expert, even though I'm here talking in front of you. So I'm not going to try to speak for every single community because I'm not part of all those communities. But I am going to tell you what we do at Howard Brown and sort of what we've learned along the way. So who are sexual and gender minorities? A couple categories here. Anyone who's not exclusively heterosexual. So we sort of define heterosexual as a person who has sex with someone of a different gender and only one other type of gender, whereas anyone who's outside of that might be a sexual and gender minority. A person whose understanding of their gender does not align with the one that was assigned to them at birth. We'll talk a little bit more about that on the slide, the next slide. And I just wanted to say, I think it's important to note the role that identity plays in this. So often when we're thinking about behavior, like people may act in ways that don't necessarily align with the identity that we sort of expect them to have based on those behaviors. And so the example I wanted to give here is that not all drag queens are transgender women, but some transgender women are drag queens. And while a man who's on the down low may have sex with other men, he may not identify as gay in like the grander context of his life. So when we're looking at categories of people, we always want to keep our minds a little more expansive. We have words and terms for communities. They may not always encompass the people we're trying to access. So sex assigned at birth. Sex assigned at birth is the determination of a birth gender by a medical provider based on the presence or absence of and size of public health oh my gosh, I need to slow down. The presence or absence and size of pelvic reproductive anatomical structures, both internal and external. This determination is typically into male, female, or intersex. Intersex is when anatomical structures don't fit the medical definition of male or female. Today we call intersex variation differences in sexual development. This is for a couple reasons. One, because intersex traits don't always appear at birth. Some intersex traits appear in puberty when secondary sexual characteristics develop. And intersex traits are about 60 developmental differences that we classify as chromosomal, gonadal, and anatomic differences. So all that to say, human sexual development, both physical and identity-wise, is infinitely variable and is certainly not binary. So gender identity. If you Google what is gender, the Oxford Languages Dictionary pulls up this definition, which is either of the two sexes, male and female, especially when considered with reference to social and cultural differences rather than biological ones. The term is also used more broadly to denote a range of identities that do not correspond to established ideas of male and female. The way that I like to think about gender in, again, a more inclusive, more expansive version is that gender is really an interpersonal construction that's dependent on social context, and an individual must understand this for themselves based on, but not exclusive of, their own physical, emotional, and behavioral traits. So who we are internally and how we interact with the world is really what constructs our gender. As much as we want it to be our own thing, people around us also construct our gender, whether or not we choose them to. And a person's identity, gender identity, may not align with the larger social perception of their gender. So a person's internal gender conception of themselves may not align with how you necessarily perceive them. This is one of the times when we just trust people on what they say. And so the project of the gender binary, I can't move forward without mentioning this, but throughout all of human history, there have been more than two genders. The current societal expectation around gender is that you either have to be a man or a woman. These are all informed by colonialist and white supremacist ideologies, and they continue to inform this existence and continue to push the political messaging that we have to be a man or a woman. And the reason that's bad is because binaries establish clear power relationships. And when you have a clear power relationship, people are really, really easily going to abuse those. Okay, so moving on to transgender and non-binary genders. Transgender people experience a gender that is different than the one they were assigned at birth, which their doctor often conflates with their sex. And so non-binary people more specifically experience a gender that is not either man or woman. A person's gender may not align with how you initially perceive them, which I've already stated. And not all transgender people necessarily want to appear like the stereotype of their gender identity. So while we have these larger societal constructions of what someone's gender is based on their appearance or the way they act, people don't necessarily want to fit into that, even if that is what their gender is. Same for people who aren't trans. I think that's like across the board. So using the person's correct pronouns is a way to affirm them, or no pronouns if that's their preference. Doing some internal work to make sure that you're practicing people's names and pronouns. If they're new to you, you want to make sure that you get those right whenever you're speaking to them in person, and when you're talking about them in the greater context to other people. And then you should work to avoid assumptions that about someone based on their perception of their gender. We should work to avoid, assumptions about everyone based on any perception we have of them. So that's, again, a bigger issue. So there's a myriad of transgender and non-binary identities. We also have cisgender women and cisgender men who are not transgender over here. And under this transgender umbrella, some people also include the non-binary umbrella, although there are some people who identify as non-binary but do not necessarily identify as transgender. So just to break this out a little bit more, there are folks who definitely identify as women and men who are transgender, and then people who identify on the spectrum of femininity or masculinity. And then there are also people who have transitioned, have decided that they are women and men of trans experience. They no longer identify as trans because they've moved into the gender and live as the gender that they truly are. And when we talk about non-binary people, there's a lot of other identities here. They all mean their very specific thing. I'm happy to answer questions about them afterward, but there's a lot of them. Mostly now we just call this group non-binary. And so moving on to sexual orientation. Sexual orientation is a self-identification that typically defines a pattern of the type of people that someone finds sexually attractive or may want a relationship with. And so sexual and romantic attraction is not dependent on a person's gender or gender expression. You can be attracted to anybody. Popular culture often defines these as same-sex attractions or opposite-sex attractions, which again, I'm going to note is a false binary, which I noted earlier. How does this leave people behind? How do we think about this? When I think, just a little aside, when I think about how we legalized gay marriage in the United States via the Supreme Court, but gay marriage didn't necessarily like fix all the issues for queer people. There's still a ton of disabled people who can't actually get married because they will lose benefits that they need to live. There's a ton of trans folks who could have gotten married based on like really, really outdated notions of their own sex already, but like, I don't know, there's just a bunch of issues here where like we can talk about marriage and we can talk about like same-sex and opposite-sex attractions, but those really don't mean anything. So I'm just here to like destroy that for you. So does being gay, lesbian, bisexual, queer, transgender, non-binary cause poor health? In general, when we talk about any minoritized group, it is always important to avoid reifying the group's minority status by claiming that health outcomes are directly caused by those minority traits. An example of this is that race is not a predictor of group health outcomes. Racism experienced due to a person's race or perceived race is what socially determines a health outcome. Again, being queer does not increase a person's chance of substance abuse. Coping with a world that is homophobic and transphobic does. So just a quick little reframe for how we think about minority groups and the health outcomes that they experienced. I've been going kind of fast, so I'm going to stop. If there's any questions, does anyone have any questions at this point? I know it's a Monday. Okay, I'm going to move on then. So real quick, I'd be remiss to not mention the HIV pandemic since we're talking about LGBTQ people. The HIV pandemic began in 1981. Over 40,000 people died from AIDS before the Reagan administration mobilized in 1987, over 6 years. After the invention of AZT, which was one of the first antiretrovirals, a group called ACT UP was a queer-led movement who protested to shorten the FDA approval process for its release. And because of a failure to respond to several stigmatized groups, including gay men, Haitian immigrants, heroin users, and sex workers, the global AIDS pandemic is still occurring. Some stats globally is that 38.4 million people are currently living with HIV globally. About 1.1 million people were newly infected last year. An estimated 650,000 people died from AIDS or AIDS-related illnesses last year. And while the goal currently is 90% of people globally living with HIV being on medication, that goal was only hit to 75%. And so we're still aiming to get a higher access to medications globally for people. And about 1.2 million people are living in the United States with HIV, and about 18% don't know their status. So it was mentioned earlier that I worked on a project called the FOCUS program where we implemented opt-out HIV screening. This 18% of people is why. We need folks to know their status so that they can continue to prevent transmitting HIV. But there's just a lot of people that we can't access, and we're still really trying to figure out why. So stigma and health access. Stigma, whether perceived or directly experienced, can lead anyone to not seek what they need in healthcare. Experiences of inappropriate genital exams on transgender people, a constant need to explain one's situation in terms of gender, misgendering, these all lead to distrust in providers and delays in care. HIV stigma also leads many HIV positive people to delay seeking care, when care can be as simple as a single pill a day. HIV stigma can also lead to potentially at-risk people not getting screened for HIV when they don't see themselves as one of those people. So the stigma around a group of people with a disease can cause people without the disease to say, well, I don't want to become part of that group, so I'm simply not going to test for it. Which, is weird how our brains work, huh? So that's just another part of that, like 18% of people who are not going to be tested for HIV, but really do need to be screened. And so here's a little chart. I should say there's a bunch of links in this, so when you get the presentation, feel free to explore it. A ton of links and book recommendations in the notes. But this chart just describes some of the discrimination that LGBTQ Americans experienced last year by some very specific groups. We can see that transgender and gender nonconforming or non-binary people experience the highest levels, and then LGBTQ Generation Z folks experience the third highest. So. Moving on, we're going to talk about stigma and PrEP. So can I get a show of hands who knows what PrEP is? Okay, cool. We were talking on Friday about how just a few years ago that would probably not be the number of hands you'd expect to see. So it makes me really happy. Many people could benefit from pre-exposure prophylaxis for HIV, which is a single daily pill that one takes to prevent the acquisition of HIV through sexual risk. And so some public health campaigns back when PrEP was released compounded the issue of people not having access to PrEP because of stigma by calling it a party drug, by just adding more stigma. So back when I was going to conferences a lot, there were a ton of talks on this because people needed PrEP and people were simply not getting it for fear of being called a Truvada whore, which is what sort of the larger community label for people using Truvada was. And it was this whole idea that if you're taking this drug to not get HIV, then you must be a slut. And which I say with a smile because I think that's so silly. But like internalized homophobia and slutphobia really compounded this issue. So it was coming from outside the community as well as from inside the community. And so while I was working as a DIS, one of the things I often had to strategize with people who were on PrEP or getting their ART was like, how do I take this without my family knowing? ART was a little different because a lot of people experience stigma from their family when they have an HIV diagnosis. With regards to PrEP, it's like, I'm doing the thing to not get HIV, like you should be happy for me, is sort of the way I always try to reframe it for people. That being said, people will always make stigma. Sorry, I went too far. So Howard Brown really worked to flip this story in the same way that many of you may know about the, just an aside, the human papillomavirus. When it was originally released, a lot of people were like, well, I don't need to get this for my kid, it's for a sexually transmitted infection. But then they tried to move the story to it's one of prevention. We saw that like vaccination rates were something like over 90% for HPV in Australia because they started with, we're preventing cancer. In America, we're preventing a sexually transmitted infection. And then parents were like, I'm not giving this to my 12-year-old. So kind of the same thing here. We're trying to make PrEP more of a message about prevention. There's plenty of other people besides gay men who can benefit from using PrEP, including transgender women, cisgender Black women, and transgender men who have sex with cis men. And this is because of the overall high levels of high levels of HIV in their community sexual networks. So just over here real quick, real quick. This is Descovy. This is the new single pill for PrEP. This is Truvada. This is the old one. If you know PrEP, you've seen this. It's pretty iconic. And then more recently, we're doing 2-month injections of cabotegravir for PrEP. So people can get an injection every 2 months instead of taking a daily pill and get the same levels of protection. You have a question?
Yeah, are some, are some PrEP meds cleared for, like, which ones are cleared for cis women? Because I know recently that not necessarily.
Not all of them. Yeah, so I think right now Truvada might actually be the only one that's clear for cis women, and there is a difference in dosing regimen for cis women or people with vaginal or front hole tissue. It takes about 21 days of daily use to ensure a clinical level of protection using PrEP, whereas for all people without front hole or vaginal tissue, rectal tissue takes about 7 days to build that up. So the regimen is a little bit more difficult. You do want to take it every single day. I'm not a doctor, so this is not medical advice, but that is how you would dose a PrEP regimen for cis women.
I've seen so many Descovy commercials. I was like, I feel like I know this. It's not approved for cisgender women.
Yeah, I think the Descovy commercials might be more focused toward trans women.
They say it in the commercials.
Okay, yeah, I was like, I haven't seen all the commercials, but thank you for that. So now we're going to talk a little bit about structural barriers. I'm sure you all know about structural barriers, but some things that people experience going into a clinic include incorrect naming, what we call dead naming, misgendering, being identified as the wrong gender, and using incorrect pronouns for people that don't match the pronouns they've asked you to use. Discomfort in disclosing trans status to healthcare providers who don't ask may result in people making anatomically incorrect assumptions about your healthcare. So trans people often have to like sort of like realign their provider with like, I don't need this because I don't have this. And that's a really uncomfortable conversation to have. A story that gets quoted a lot in trans health research is transgender broken arm syndrome. I see a smile in the back, so clearly some of us know what this is, but we call this transgender broken arm syndrome because of this quote from a paper about rural experiences of transgender people getting healthcare. Someone went in for a broken arm and their doctor was extremely focused on the fact that they were trans and not the fact that their arm was broken. And so the doctor continued to be like, well, you know, is it broken because you're trans? And it's like, we laugh at it, but it's honestly like, they're like, no, like, why would that be the case? And so the person who was quoted said, I believe their name was Bailey, said that like, you know, if you're cis and you come in for a broken arm, your doctor's like, you have a broken arm. If you're trans and you come in for anything that's not related to your transness, they will say, oh, is this because you're trans? So you have to go through that whole layer of explanation before you can even move forward. Some other issues that people run into include billing departments at healthcare organizations who don't know how to bill around gender marker changes. So a lot of people will get bills they weren't expecting because their insurance was supposed to pay for something, but some insurance reason said, oh, well, you're a man, you don't need a pregnancy test. So like at Howard Brown, we have billing managers who know how to bill around these types of things and actually like train other people on how to do that. It's gotten a lot easier with regards to, well, I guess it's gotten easier with PrEP because a lot of PrEP gets paid for by insurance companies now, but yeah, it's just one of those things that you gotta kind of understand and move through. And then I'm not gonna go really into depth with this because I'm sure you all know, there's a lot of anti-trans legislation that's banning gender-affirming surgeries and even hormones statewide for children and adults alike. So that's not great. I'm not a policy wonk, so I'm not going to go into that, but you can look it up. So what are some of the ways we can fix this? One of those is with getting more queer providers. There's simply not enough healthcare providers in our health system that understand trans and queer people. And so in 2019, a study showed that medical providers state that they still feel unprepared to assess transgender patients, even if they feel prepared to assess lesbian, gay, or bisexual patients. And I will say, medical providers feeling prepared to do something doesn't mean that they're going to do it or do it well. So whether or not they feel prepared, I doubt they're even prepared to fully assess lesbian, gay, and bisexual patients too. And then many queer health clinics like Howard Brown exist simply because we recognized that no one was going to do the healthcare we needed. So Howard Brown was created to do that even before the AIDS pandemic. Howard Brown was started in, I think, 1974. And so if an institution isn't going to serve our needs as a community, we have to build the program and institutions that can. Okay, so going over some more of the inequities, overall community tobacco use in the LGBTQ community is high. You can see over here by tobacco products, transgender people across the board use tobacco products more than cisgender people. This is from a 2013 study. And then we also have LGBT or more LGB folks who have about a 90% ever use of tobacco across the board, and about a 60% past 30-day use of tobacco. So in 2013, Howard Brown made a program that we called Bitch to Quit. And this was specifically an LGBTQ-focused program for tobacco use cessation. So focusing on sort of the motivations of why LGBTQ people were using tobacco to begin with, and then working with them and through that to help them get to a point where they felt safe and comfortable stopping using tobacco. And as far as I understand, it was a fairly successful program. I came in about the time that it was ending, so. A couple other things to mention, Tea Party and methamphetamine and GHB use in the gay community has become an ever-growing issue even through the pandemic. There's a lot of other drugs that exist in the community too. You can really just search it on PubMed and it'll be there. But the bigger point I wanted to make to this was that typically at Howard Brown and around other queer health organizations, we work under a framework of harm reduction. And we will never try to push a patient into like ceasing use of a drug or a substance until they're ready or until they have this like supplies and structure that they need underneath to make sure that they can make that change. Because we recognize that you know, people won't stick to things whenever they are not supported or prepared to. And simply, we also kind of have I would say community-wide, we sort of have we lean toward like, people should be able to explore and play with their desires and pleasures as long as it's not harming them or the community, and then we kind of help people out of that if they need that help. Some other substance use issues include street hormone use by trans folks and silicone injections. Just real quick, there was about a 17% of illicit silicone injection use in transgender women in a 2013 LA study. Oh, sorry, 2013. That's a different study than the 2018 study above. But the point being that injecting silicone on the street can include risks like HIV, Hep C, and hepatitis B. And that having social networks with trans friends who correctly use hormones mitigated misuse of hormones among these people. And then also to note that anything that is specifically an LGBTQ health inequity, you can also just add any other health inequity from any other identity that also occurs and add that into the community because you know, the opioid crisis has not left the LGBTQ community alone. LGBT women and bisexual men have an elevated opioid use risk, and bisexual women experience almost 4 times the risk of injection heroin use versus straight women. And so both LGBT women and gay men had 1 to 2 times the odds of past-year opioid misuse. Quick pause. Any questions at this point? Okay. So talking about mental health, 2018 systematic review of 77 trans mental health studies between 1997 and 2017 found that TGNC people are exposed to a constant variety of social stressors, including stigma, discrimination, and other bias events. I'm not sure what they meant by that, but to me, a bias event is stigma and discrimination. But these contribute to mental health problems, including depression, anxiety, substance use, and suicidality. So we have to remember that in the wake of a transphobic society, social support, community connectedness, and effective coping strategies can be beneficial. And in a UK review among LGBT people, there was about a 1.7 times the odds of common mental disorder. Again, depression, anxiety, substance abuse, and suicidality. This was also much higher in people aged 55 plus. So if you're familiar with life course theory, we have to think about how you know, stigma and stuff builds throughout your life, and you just continue experiencing it as you get older. Talking about some of the work we've done with mental health, I mean, obviously we provide mental health and therapists and psychiatric care, but what we do on the side is sort of make sure that there is access to mental health across the city, because we can't provide mental health services to everyone in the city. And we're constantly booked out. So one of the papers that we're working on is redoing Chris Rosenthal's 2016 paper on the racial and socioeconomic inequity of spatial distribution of LGBTQ human services, spatial, not special. In 2016, LGBTQ human service sites were disproportionately located in white, non-Hispanic, Latino, and upper income Block groups. So around 60 to 70% were in like richer, whiter neighborhoods, essentially. And our behavioral health department, like I said, is working to reproduce this study. This is some of the mapping work that I've done so far, showing the green dot, all referral locations that Howard Brown feels comfortable sending people to across the city. And then when we break this down even more, this is when we look at sort of the heat map of zip codes that have LGBTQ affirming clinics. And then whenever we start to think about if these clinics are affordable, we see that Chicago is essentially a massive desert of cheap, affordable mental health services for LGBTQ folks. And on top of that, we also see that there's essentially none on the South Side. So this continues to be an issue, just like the 2016 paper. Yeah, that's probably going to be the outcome of that paper, is that, oh, guess what? Not much has changed. So some other things. I'm quickly going to be talking about sexual violence and IPV. So Howard Brown did create a team called the Empower Team, which was specifically created to respond to sexual violence experienced by LGBTQIA people. At the beginning of the pandemic, there was a huge issue with medical forensic exams or rape kits being administered in hospital settings where they were completely overrun by COVID cases. And so we actually lobbied the state of Illinois at the beginning of the pandemic to allow federally qualified health centers like us to provide MFEs. And we did provide MFEs throughout the pandemic until we were unable to staff the program anymore. I believe the temporary law that like created our ability to do that is also expiring due to Chicago's no longer being in a pandemic, or whatever people are saying these days. Obviously, we all know that's wrong. Just some other notes: bisexual women experience intimate partner violence at almost twice the rate of exclusively heterosexual women. Non-monosexual women, which is sort of bisexual plus, experience IPV rate at 78%. And then when we look at, again, bisexual men, we see IPV in about 1/3 of relationships. Okay, this is an important slide. So people, not just women, get abortions. Transgender men, non-binary, and gender expansive people getting abortions deserve to have their gender respected and affirmed throughout that entire process. In a 2020 study in the American Journal of Obstetric Gynecology found that non-binary and transgender men 3-to-1 preferred medication-based abortion. This is primarily for the privacy and accessibility aspects. And they also requested that abortion and gynecological care centers are less gendered and have more expansive gender options in forms and pamphlets. So not surprising, if you're a man going to the doctor's office, you might not want to see an office full of pink whenever you're there to get some gynecological care. I think this also goes a lot for, well, I'll talk about that in a different slide. So, okay, we're gonna talk about homelessness and survival work. While LGBTQ youth are estimated to make up 5 to 7% of the youth population, they make up about 20 to 40% of the homeless youth population. Street-based LGBTQ young men are up to twice as likely to be involved in the sex trade as their heterosexual counterparts. Having unstable housing makes things like having continuing education, getting and holding a job almost impossible. So when we see people doing things like survival sex, it's often so that they can gain some ability of stability in their life to be able to move out of that. And that's why we see rates that are higher among LGBTQ youth, because they are ultimately like more vulnerable and more minoritized than their heterosexual counterparts. And so Howard Brown does have a drop-in center called the Broadway Youth Center. It's up on Sheridan and Irving Park, and it aims to provide social services and healthcare to youth who need it throughout the day. It's a place you can like get a meal, get a shower, get some healthcare. Another place that I got to visit once was the Phoenix Center in Springfield, Illinois, which provides housing to rural area youth who are made homeless by parents upset by their likely newly announced LGBTQ status. It also provides job skills training, access to computers, and housing, so people can actually get mail there if they need to. And they can stay there for, I think, up to like 2 months. Okay, we're getting toward the end of the inequity slides. So I'm going to talk about cancer and the LGBTQ community. The American Association of Cancer Researchers, using NIHS data, estimate that there's a 50% odds increase in gay men and a 70% odds increase in bisexual women of reporting cancer diagnoses in their lifetime compared to their straight counterparts. Anal cancer in particular is experienced in up to 20 times higher in men who have sex with men, specifically those who are HIV positive, compared to heterosexual men. And this is from a study called the SPANK study. And while the results aren't out from the SPANK study yet, some of the preliminary results show that anal HPV infection is almost universal in men who have sex with men over the age of 35. Among 32% of HIV negative men and 47% of HIV positive men, these folks have high-grade squamous intraepithelial lesions, which is the precursor for anal cancer. So I was talking about human papillomavirus earlier. That's what these HSIL precursors are. And so Howard Brown Health has a specific anal clinic for diagnosis and treatment of anal cancers because we recognize that this is something that men in our community are not getting access to. And then we also have to think about prostate cancer. And so in a 2016 meta-analysis found that there's a lack of research on gay prostate cancer outcomes. But of the research that we do have, we see that gay and bisexual men are screened for prostate cancer less, they're diagnosed at about the same rate, and they have worse sexual function and quality of life outcomes after a diagnosis and treatment. And so what this indicates to me is that we need more surgeons who are sensitive to the stigma associated with loss of sexual function in gay men. Okay, 12 minutes left. So real quick, these are some of the stats on sexually transmitted infections at Howard Brown Health, because I think this is maybe one of the ones that folks know the most, but LGBTQ people do have higher rates of STIs pretty much across the board. Again, this is not by a function of them being LGBTQIA, it is a function of being unable to access healthcare because of identity statuses. And so gay and bisexual men and transgender women of color are by far the most impacted by new HIV infections in the United States. Young cisgender MSM of color have the highest rate of infection at Howard Brown at about 3% for HIV. An HIV positivity rate for transgender women of color is about 2%. So these are populations that we really focus on doing outreach to. HIV may be decreasing overall, but currently that's a little difficult to tell because of trends in the COVID-19 pandemic. My PI, Maria Pira, is writing a paper about that. And then if you look at some of our testing stats in 2015, when I started working at Howard Brown, we were testing about 10,000 people a year for HIV. And at our peak before the pandemic, we were testing about 23,000 people a year for HIV. And that's unique patients, not number of tests. Some people get tested more than once a year. So a quick note on bacterial STIs. Something that I think it originated as an idea at basically queer health centers was that we just sort of knew that there had to be higher rates of gonorrhea and chlamydia that were being experienced by people, but we weren't detecting it for quite a few years. And so there was a move, I believe in 2015-ish, to start doing more extragenital swab testing. So this got a giggle on Friday, but no wonder patients don't want to get a rectal screening for an STI, because before we allowed them to self-swab, they would have to have their provider stick something in their butt. Typically, you don't want that to happen with your medical provider. So it was a lot easier for us to train our, basically train our community on saying, this is how you self-swab. We trust you to do this. Just follow the instructions and we'll get your screening. So now we're able to swab people's vaginas, rectums, and the oropharyngeal area for gonorrhea and chlamydia. And we're actually getting a ton more infections that we've recognized because of using that modality. So one of those things where it's kind of obvious to us now, but for a while it was like, oh, well, we should be able to get most STIs through a urine test, right? The case for our community, that's not necessarily true. And so just some other stats on this. Like people who are less than 30 years of age in Chicago account for the majority of our bacterial STIs. And here's some of the chlamydia and gonorrhea rates among different gender groups at Howard Brown. Talking a little bit about syphilis. Syphilis is a large issue for men who have sex with men. Prior to about 2001, it was a larger issue for Black women. I believe it's still an issue for Black women, but in Chicago at least, the epidemiology has moved more toward MSM. This was due to an outbreak at International Male Leather in 2001. If you know what that is, it's a giant leather sex fest that happens downtown Chicago every year. One of our community events. And so someone in 2001 had a syphilis case that apparently spread throughout that, and that's how the epidemiology of syphilis changed in Chicago. So now syphilis is a big thing that we focus on. And I was discussing earlier some of the disease intervention specialty work that I did. This was specifically with syphilis and HIV cases. So some of the steps that we took with that were that we interviewed people with new syphilis infections. We made sure that we knew when they were, well, we made sure that we could try to find the infectious period that they would have potentially spread it to someone else. And so what we did a lot of was determining that infectious period and then talking to the patients about who they had sex with in that infectious period. And then what I would do is call those people up, like cold call in the middle of the day and say, hey, someone you had sex with has syphilis, and we just wanted to let you know so that you could come in and get a test and that we could get you the proper treatment. You can imagine that phone call did not always go very well. I got yelled at a lot for about a year. But it's important because you want to get people screened and treated as soon as possible, because if you can get someone screened and treated, it means they have one shot in the butt, versus if they have had a syphilis infection for an unknown period of time, we have to give them 3 shots in the butt 3 weeks in a row. So for our patients, that also means a lot, because not being able to sit for 1 week versus not being able to sit for 3 weeks is a big life difference. So. And then just to talk quickly about monkeypox. Monkeypox is not a gay disease. It just happens that in this time it has spread rapidly through a network of sexual connections that are extremely strong and run throughout our entire community. So monkeypox at Howard Brown since September 2nd, we had tested 743 people for monkeypox, of whom 359, or about half, tested positive. We've also distributed 8,600 monkeypox vaccines, including 25% of that entire group who have had their second vaccine as well. So monkeypox is on the decline currently, and one of the reasons I have to think that that is true is because queer health centers across the nation really did respond to this as an issue. Like, this is one of the reasons we exist, is for response to epidemics. And so seeing that we were able to distribute the vaccine as quickly as possible is probably why we're seeing this lower now. And also, monkeypox is not a disease that really like killed people. There are a few people who died, but the severity was quite different than COVID-19. Okay, so this is my last little slide. I'm going to go over it quickly. There is a link to a YouTube video that if you really need a good cry, you should go watch. I'm not going to make us watch it on a Monday morning, though. So this is a talk that I saw at the Gay and Lesbian Medical Association conference in 2019 by a woman named Kimberly Aquaviva. And she was talking about her wife, Kathy Brandt's dying process and the experience of going through palliative care as a queer woman, being married to another woman, and sort of their experiences. And so because they both were palliative care researchers, they decided that it would be most important to like show their entire story throughout the process. So they were just tweeting constantly for about a year while Kathy died, was sort of like all the ups and downs and everything that was involved, which sounds a little wild, right? Like to just put yourself out there so vulnerably, but I think it's important because they really wanted to show that the dying process is different for queer people. And they also, like, you know, they're part of this work, so they wanted to almost do an experiment of like, what actions can we take to make this easier on us? And so some of the things they did included setting boundaries about what they were willing to hear regarding their diagnosis. Kathy was terminal. She did not want to hear about people who had fought cancer and survived. They wanted more options for palliative care at home. Kimberly specifically mentioned safer hospice care for queer people, because again, like, queer people like die just like anyone else, and we also still want to be ourselves whenever we're in that process. So another thing she mentioned that was big for Kathy was access to medical marijuana, psilocybin mushrooms, or other psychoactive drugs that lessened existential dread. She said really helped Kathy throughout the process. And my last note here is really just that queer people deserve to be able to be themselves up until their dying breath. And I think as we think about LGBTQ health inequity, we often think about like young LGBTQ people because that's where a lot of the health inequity lies. But like the truth is we continue living until we're dead like anyone else. So, you know, we continue needing care throughout that entire process. Anyway, watch the video. It's a good one, I promise. Okay, are there any questions up until this point? We're at 43 minutes. Okay. I'm going to talk about me now. So do you have any questions about health inequities?
Oh yeah, we do. Sorry, one question from someone who's online.
Okay, cool.
They asked, is there any collaboration with the Puerto Rican centers? They have a service where they can help house individuals that are made homeless from their status as LGBT. So is there any collaboration with other centers?
Yeah, with PRCC. I do believe we collaborate with PRCC, though I can't note the specificities of that off the top of my head. But we do also have a clinic at La Casa Norte, which is, I believe, a family housing center for up to 50 families on the west side. I haven't visited that site, but we do have a collaboration with places that do house people experiencing homelessness. Anyone else? All right. So if anything else comes up, just let me know. I'm going to tell you about how I got to where I am here. It's a little twisty and curvy, sort of like most of our public health experiences, I think. So I first kind of became interested in disease when my grandpa handed me a copy of The Hot Zone when I was 12 years old. This is a book about an Ebola outbreak in monkeys in Reston, Virginia. It really kind of piqued my interest. And then a year later, I got diagnosed with type 1 diabetes. And so my understanding of disease changed from sort of this like thing out there that was infecting people to like a chronic condition I would have to live with forever. And so along with that, like learning how to deal with insurance, the struggles of paying for insulin and pump supplies, I also developed a huge understanding of inequity and unnecessary barriers that we put up in front of healthcare, specifically insurance. But I also participated in a lot of diabetes medical trials, and I was one of the first people in the state to get a continuous glucose monitor approved for people under 18. So they let me use that as a 14-year-old, which is cool. When I went to college, I went to Case Western Reserve thinking I was going to be a biomedical engineer, and I failed calculus in my first semester. So with another professor's encouragement, I decided to move into plant ecology, which I was much more interested in. And so I learned some programming languages and got to do that. And at the same time, I also took a class called History of Diseases, where I read And the Band Played On, which is a tome of an accounting of the HIV pandemic, the early years of that. Cannot recommend that book enough. I then also took a short-term study abroad to Amsterdam, where we met with legislators, sex workers, and observed nurse-assisted user rooms and drug-supportive housing. So if you don't know what those are, user rooms are places in Amsterdam where people who are injecting drugs can inject drugs and test their drugs in the presence of a nurse who can help them out of an OD if that becomes an issue. And then they sit, use their drugs, and then go on their way. Another thing that Amsterdam had was drug-supportive housing. So they had a lot of large housing facilities where people could essentially get free housing, live there, and people could also use their drugs in that free housing until they were ready or not ready to move into a rehab facility. And so, yeah, those were just two really interesting like observations on that trip where I was like, oh, you know, we don't actually in America have to treat people like we do. like people who are using drugs or who are abusing drugs like actually need our help and need our support. They don't need to be told what their life path should be. So that was just kind of an interesting reframe that happened to me in college. I skipped over that last time, but after college, I became an intern in a few different departments at the Sangamon County Department of Public Health, which is down in Springfield. I got to do some very fun things, including health inspections at the Illinois State Fair, where I did get to shut down a booth for an hour because they had rainwater dripping off of their roof onto their grill. Exactly. So more, yeah, I was like, I have so many stories from that summer, but let's just say I do still eat at restaurants warily. I also got to work on some clean needle exchange outreach. I got to visit some LGBTQ youth housing at the Phoenix Center. I evaluated their teen pregnancy prevention program, which they desperately needed evaluated, and was very unfortunate to see because they didn't have the same pre-test as they had post-test in whoever developed their materials. So I said, I unfortunately can't tell you much. That's the evaluation, but I think they learned an important lesson there. I also did some home health outreach where we help people set out their pills for an entire month so that they wouldn't have to worry about doing that on a daily basis. And then in my first week, I actually got to deliver some directly observed therapy for the only tuberculosis case in Sangamon County. They were very friendly. I think they were also tired of sitting in their house. In 2014, I started my MPH program here at UIC. I started in this very room. The same year, I decided that I should go see an endocrinologist in Chicago because I have diabetes and I should be getting checkups. So this is just an interesting experience of discrimination right when you walk into your doctor for the first time, when she said, oh, are you a hairdresser? Because I had bleached hair and painted nails. And I said, no, I'm actually an epidemiologist, and never went back to see that doctor again. In 2015, my UIC advisor, Dr. Mehta, connected me to Howard Brown Health and my first boss, Chad Hendry. And I got to work with him as an HIV and syphilis DIS until the summer of 2016. In 2016 is where I started working on the Focus program. So like I said, we were trying to build programs through this grant from Gilead that a lot of people across the country were working on, where we were essentially moving to an opt-out model of HIV screening. So instead of only providing an HIV test when someone says, oh, I need an HIV test, or asking them, do you need an HIV test? We said, we're going to give you an HIV test unless you refuse it. And that got a lot more people tested for HIV. With that, I was really lucky to travel around and present my work. I met a ton of people. I can't recommend going to conferences enough. I know it's a different time in the world to go to conferences, but and then after that grant, I took on a program evaluation role at Howard Brown, basically just doing any kind of database stuff that they needed for evaluating effectiveness of a program, or like seeing a population that we needed to target for a certain health metric. And then in March 2020, like most of us, I was sent home to avoid the COVID-19 pandemic. About a month later, I became the manager of data and evaluation at Howard Brown Health. Since then, I've helped with our COVID-19 reporting. I've built out our data team so that we have more capacity to do research and write papers. The 3 papers I've been working on, which I got another email back from this morning, was trans men and factors associated with eligibility and initiation of PrEP, factors associated with the receipt of primary care for transgender and non-binary patients, and then those maps I showed earlier, the availability and distribution of affirming mental and psychiatric health providers in the Chicago area. So I am sort of our clinic's geographic information systems person. If you haven't seen that class, I think they still teach it at the School of Public Policy. I don't know if anyone knows that, but you should definitely take a GIS class if like data is your thing. And then in the last 9 months, we've been moving our medical record system over to Epic, which is going to be great for us, but has been about a year of pain and agony. All right, and so here we are, coming full circle, teaching you today. I'm really happy to be here again. Thanks for having me on this Monday morning. And I think we have like 10 minutes for any and all questions. So literally ask me anything. I'm an open book. Or don't. That's also fine. Thank you for having me. Yes.
So I know at the umbrella slide,
Mhm.
non-binary, there are a couple of terms that didn't recognize
Sure.
Non-binary. I think like trigender and neutral.
Yeah. Okay, so like I said, I don't speak for all communities here. I'm going to do my best. I identify as non-binary, and I also identify as genderqueer. So I do that because my gender has always felt very in flux and is really hard to pin down at any point in time. Bigender people typically experience like two genders and like sort of very strongly on either end. They don't really do much in between, so they feel one way or the other at any point in time. Agender folks typically say that they don't really feel much about gender at all. Pangender people feel that they experience a vast array of gender. I think usually they sort of say like constantly and always. If someone's pangender in the room and is, I'm butchering this, let me know. Gender fluid, again, is more about gender fluidity. I think genderqueer and gender fluid sort of overlap in some ways. Neutroy, again, I believe is more like agender, but it's sort of more of like less like no gender and more like completely neutral gender. Anyway, nuance. Trigender, people who experience three genders in that sort of bigender way, but like +1. And then two-spirit people, which I have a little note down here, was a term created by the elder Myra Laramie, who it was originally proposed as sort of a catch-all gender for a lot of various indigenous gender experiences that you know, were typically, I don't know, they weren't defined in Western rhetoric and like probably shouldn't be. So this was a word that was created for that. I hope that helps. Any other questions? Sure.
How does Howard Brown get its funding, and how do you like outreach to?
Yeah. So specifically with outreach, I should say that we have done a lot more outreach before the pandemic. Since the pandemic, our outreach has really been focused on vaccination for COVID and testing for COVID, as well as vaccination and testing for monkeypox. What we do typically do for outreach is we go to community events and we go to community spaces. So that includes things like gay bars, like places where people hook up. Occasionally we send some people to, like, if we know there's a big sex party happening, we send a couple people to like go do on-site testing. And then places that are like bathhouses, like Steamworks, we have a weekly testing site that we go to for there too. What was the other part of your question?
How does Howard Brown get funding?
Oh, funding, yeah. This was a question in the last class too, because it is important to note that a lot of LGBTQ health funding is centered around AIDS and HIV. And so the question, I'm gonna answer your question with a different question. So last week the question was, how do you flex around what a grant requirement has of you versus what the money actually needs to go to? And I think Howard Brown sort of takes a stance of do what needs to be done and ask for forgiveness later. And so if we have funding that is like specifically for, you know, say it's for like PrEP prevention, and it's been, you know, it's like we defined a population or something, but like we're not going to just say we're only going to give PrEP to this population. Like if people who really do fit this need, like need PrEP, then we will do that under that grant. And then later when we report back to the grant, we'll say, oh, by the way, we also did this. Sorry. Like, are you going to say we should have given money to people for PrEP? Anyway, so that's kind of like how we usually do with that. Our funding actually mostly comes from like billing for services now. We used to have a lot more grant funding, but yeah, most of our funding comes from billing for services. Though, if you can't afford services at Howard Brown, we do have a sliding scale, so you won't have to pay anything if you can. thanks for that.
How do you, like, for people at Harvard Brown train with kind of cultural competency, like with the, like, two-spirit people, or like any other sort of, like, kind of like other culture definition of gender and sexuality, like, how do you approach that?
Yeah, we have a series of onboarding trainings that we give folks. I will say most people who work at Howard Brown are queer in some regard, and so a lot of us sort of come in with that knowledge. But we do give gender-appropriate language trainings to people coming in, and we do have a specific provider program that we train providers in, because I think it's more so like more of our providers aren't queer, but we do train them on interacting with the community. And we also like keep up with them if we notice there are issues. So we do have a pretty robust way of dealing with patient grievances. So whenever we get patient grievances, we also filter that back out to whoever sort of needs re-education or needs information. But yeah, there's a lot of trainings. We're always in trainings. Yeah.
So I know you kind of talked about like legislation and things like that, but do you feel, and if you feel, how has like the political climate in the last 2 years impacted your job specifically? How you should
Yeah, that's a great question. My job specifically, like personally, not too much. I think one of the big things that we've had to deal with in the last couple of years is how we document pregnancy and abortion. Both are things that we have to report in various federal reporting systems, and so yeah, we're always sort of having conversations around like how do we flex around whatever this new legislation is to ensure that we can continue providing care, but also to ensure that we're protecting our patients along the way. Because like we don't do abortions in-house, but we do provide information about options for people. We only provide information about options, because if we use certain words or they get recorded in the medical, at least during like the Trump era, if they got recorded in the medical system, they could possibly be used as a way to target a patient or a way to target our federal funding, which we do need to provide services. So it's always like the political framework is always making our lives more difficult, and we're always just continuing to like flex around it as best we can. I think the upcoming thing we're going to run into is that states around us have almost unanimously banned abortion, and so like while we don't provide abortions now, it has been on the docket to do that for a while, and we do have a new 5-story facility being built. So I think when that facility is in existence, we may be able to start doing more programming around that. I hope that answered the question. Okay. Yes. Yeah, we see patients from literally everywhere. Some people actually fly to Chicago to go to their Howard Brown appointment. Like that was one thing I actually wanted to mention in the transgender broken arm thing, was a structural barrier around how if you are in a rural area and you don't have providers who provide the kind of care that you need, you may have to drive hours and hours to receive that care. Whereas anyone else who just needs to get a normal healthcare thing can just go to a regular doctor. There were a few instances where someone said, I have an endocrinologist. So like it's like someone who's like doing their trans care on the hormone level, and they were only able to see them if they drove 2 hours one way, saw them for an hour, and then drove 2 hours back, which meant they also had to take a day off of work. So you just kind of like compound those layers of like, pardon my French, but like bullshit that people have to deal with just to get healthcare. Yeah, but we see people from all over. So there's also no restriction. You don't have to be from a certain area to be seen by us. Anyone else? Yeah.
Does Howard Brown still take like interns during the summer?
They do, yes. So let me get back to my last slide. You'll be getting these slides, but that's my email. If you're interested in doing anything regarding queer health, send me an email, especially if it's data related. If it's not data related, I can try to get you into a different department at Howard Brown, but we have taken on interns, and we are ready to take on interns next summer. So let me know. Or send me an email before then to just chat. I'm also into that. Anyone else?